Welcome everyone to today's webinar. I am Mackenzie Bean, Managing Editor with Becker's Hospital Review. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. This session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. It's now my pleasure to introduce today's presenters. Dr. Greg Miller is Chief Medical Officer at Vituity, overseeing performance improvement programs and the development and dissemination of best practices. He provides leadership in the areas of risk management, quality, continuing medical education, CMS performance, patient experience, operations flow, and data management. Dr. Dylan Carney is MAT Program Director at Vituity and practices emergency medicine at Marin Health in Green Bay, California. Dr. Carney champions the adoption of evidence-based treatment for opioid use disorder across more than 100 emergency departments, developing educational content to train emergency physicians in ED-initiated MAT, and guiding departments through the operational steps of ED-MAT implementation. Dr. Candice Fong is Assistant Vice President for Medication Safety at Common Spirit Health, with oversight for opioid stewardship, antimicrobial stewardship, and regulatory compliance. Her role under opioid stewardship includes the system standardization of the MAT programs, opioid prescribing practices, as well as the system standardization of ALTO guidelines. I will now turn the floor over to Dr. Miller to begin today's presentation.
Well, thank you very much. Hi, everyone. My name is Greg Miller. I'm an emergency room physician based in Seattle. I think I probably speak for everyone on this call, both the presenters and the audience alike, when I say, it's actually a huge relief to be talking about an epidemic right now that is not COVID-19. Preparations have been really fast and furious here in Washington for the coronavirus, and I'm sure they are in your own institutions as well. So just want to start out by appreciating everyone for all their hard work. I know we're all working tremendously hard to address this really fast-moving epidemic, and I know how stressful the COVID epidemic is, and I just want to remind everybody that we will get through this. But let's talk about a different epidemic. We're going to talk about an epidemic that's killed 20 times as many Americans as individuals who have died worldwide from COVID so far. In this talk, we're going to be reviewing the impact of the opioid epidemic. And we're going to discuss how ED-MAT or MOUD works. MAT is medication-assisted treatment. The term is being supplanted by MOUD, which is medications for opioid use disorder. But we're going to be sticking with the terminology MAT, as that's probably a little more familiar to a broader audience. We know that MAT decreases mortality in outpatient settings. That's been well proven. And here in this lecture, we're going to talk about the effectiveness of MAT in the acute care setting, not the outpatient setting. And this setting is often overlooked as a source of treatment for patients. We're going to discuss some proven success that we've had in patient outcomes, and we'll discuss how hospitals can operationalize MAT in the emergency department. These programs can be really difficult to get up and running. But hundreds of EDs are already successfully doing this across the nation, and your emergency department and acute care hospital can do so as well. Let's talk a little bit about where we are currently. The opioid crisis is no surprise to anybody on this call. It's a nationwide public health emergency. In 2017, 72,000 Americans died from overdose. In comparison, about 3,500 people have died internationally from COVID-19 so far. So this is a tremendously impactful epidemic. 68% of drug overdose deaths in 2017 involved in opioid, and the remainder were due to drugs like methamphetamines or benzodiazepines, and of course, prescription drugs like beta blockers or over-the-counter drugs like Tylenol. We've seen a six-fold increase in annual drug overdose deaths between 1999 and 2017. Unfortunately, many of these patients never make it into the emergency department because they're found too late at home by their friends or family. But in the ED itself, we have seen a dramatic increase in opioid-related visits over the past several years. When I first started in emergency medicine, opioid-related visits were still relatively rare. Now, every single shift I work, I see at least one or two patients who's there for issues related to opioid abuse, whether it's an overdose, an abscess, endocarditis, dealing with chronic pain, and withdrawal, etc. Numbers have more than doubled over the past 10 to 15 years in the emergency department. In 2006, or 2005, there were 89 visits per 100,000 population. That's more than doubled now to 243 visits in 2016, and those numbers have continued to climb. Unfortunately, for everybody who works in the hospital, as we all know, this is not just an emergency department problem. This is impacting our inpatient units as well. Patients who have opioid use disorder tend to be a lot more complicated, both medically and socially. And this leads to diseases such as endocarditis or osteomyelitis, diseases that require prolonged antibiotic courses that frequently have to be delivered in an acute medical setting, as the home environment of these patients aren't conducive to PICC lines or outpatient nurse visits. So naturally, the cost is tremendous. I was actually surprised to see this stat that 53% of patients with opioid use disorder are admitted. I think we certainly have a perception in the ED of a frequent flyer who kind of comes in and out, always there, but not that sick, just kind of overutilizing services. And we don't really realize how serious the underlying condition of opioid use disorder is and how high the rate of major complications is. Whereas, in fact, a patient who presents to the emergency department with an opioid overdose has a higher one-year mortality rate than a patient who presents to the emergency department with a ST elevation, myocardial infarction, a major heart attack. So this is a disease with a lot of financial burden. If you assume the average ED visit is around $500 and the average inpatient stay is around $10,000 and the average ICU visit is around $20,000, then this is costing our society $11 billion a year. And you can certainly, pick apart these numbers, but there's really no way for us to really quantify how much in dollars this epidemic is truly costing us. But we all know it's a lot. And we all know that more than dollars, this is really just tearing apart some of the fabric of our society. And it's not really about this $11 billion. I think everyone on this webinar has been personally impacted in some way by the epidemic. Many of us have friends and perhaps family members who have struggled or even died due to the epidemic. Just personally, in the past few weeks, my own preschool-age son, he has a playmate who just came over. They play together frequently, and she's cared for by her grandfather because her mom's on the street struggling with heroin addiction. I know we all have other stories, too, about how maybe this epidemic has hit even closer to home. So it's not about the dollar figure. It's about the real impact that this is having on real human beings, on all of us in our society. And unfortunately, despite the tremendous financial and emotional impact of this epidemic, our current system in the emergency department is not well set up to help patients, at least in the acute care setting. The patients are often marginalized in the emergency department. Nurses and physicians, physician assistants, techs, other staff, we've all been verbally abused. Some of us have even been physically assaulted by patients with opioid use disorder. So it's no wonder that there's a lot of reluctance to engage this population from caregivers who honestly are otherwise incredibly empathetic and committed to other patients. But we've learned with this population a learned sense of helplessness. We've learned to focus on the acute medical issue rather than the underlying medical disease. And we often feel like this is just a revolving door, like we just patch people up for a short period of time, maybe with an IND of an abscess or a prescription of Keflex or Bactrim for some cellulitis, maybe a prescription of naloxone for an overdose. And we all know that these patients will be coming back. And at best, the most any of us really do is to give them some contact information for an outpatient treatment center. Maybe we do a brief expert. But we know that these centers are full. We know they're difficult to access. We know they're expensive. And we know that these patients are going to come right back to us. And so there's this real sense of fatalism, of learned helplessness. We feel like there's nothing we can do for these patients in the long term. And if we do try to do something, we're just going to be digging ourselves even deeper in a hole because we'll start seeing even more of these patients. But the reality is, it does not have to be this way at all. There's a much, much better way to manage this epidemic in the emergency department, a way that gives hope to both patients and to an overwhelmed and burned out staff. So we can certainly do better. And by doing so, we're going to be able to help both patients and ourselves working in the emergency department and acute care setting. And with that, I'll turn it over to Dr. Dylan Carney.
Great. Thanks a lot, Greg, for kicking us off with that great introduction. I'm going to pivot a little bit and discuss how MAT has really moved from the outpatient arena into hospitals and emergency departments over the last few years. This has really been driven by research from Yale and other academic institutions demonstrating that this is both a very feasible and highly effective strategy, specifically when it's initiated in the emergency department. Now, MAT is a concept that most people are already familiar with, even if you haven't heard of it by name. It refers to the idea of using medications to help minimize cravings and treat symptoms of withdrawal and help a patient gain control over their substance use disorder. It's the same concept we employ when we treat nicotine addiction with nicotine gum or a patch, and it's incredibly effective. For opioid use disorders, this means using medications like buprenorphine, methadone, or naltrexone. Some of these medications, like methadone, have already been in use for a long time, but traditionally they've been unavailable or thought of as too complex to start out of the emergency department. This has, of course, all changed over the last few years as we've seen the volume of ED visits for opioid-related problems skyrocket. And these opioid-related visits take one of several flavors, either opioid overdoses requiring Narcan for reversal, complications of opioid use disorders such as abscesses and bloodstream infections, or just simple opioid withdrawal, either unintentional or intentional. I actually remember my first opioid withdrawal case when I was in residency. It was a patient who came in because they knew they needed to get off of the opioids that they had started for back pain a year ago, but the withdrawal was too severe. At that point, there wasn't much that we could offer to the patient aside from another dose of the opioid he was already taking or a taper, which he, of course, didn't want to do. So we gave them a referral and we said, try to call this opioid treatment program and get in for an appointment. And that's not particularly a satisfying solution for that patient. I want to get a little bit more into the specific details about how this works. The first step is to identify the right patient population. These are traditionally patients who are already in withdrawal. That means that even though we may have a very high rate of opioid use disorder in our emergency departments, only the subgroup of patients in withdrawal can start the medication. That's because of how the medication works. It simultaneously both activates and blocks the opioid receptor. This means that giving buprenorphine to someone who is actively using can actually cause or precipitate their withdrawal. But when we give it to someone who's already in withdrawal, it does the reverse. It alleviates their symptoms and it can completely take away their symptoms. So this became a great option for two types of patients. Patients who already quit and are symptomatic, or patients who just received Narcan from an overdose and are now withdrawing. The next step is to start them on the medication. Again, this is something that has been simplified significantly over the last few years. The clinical aspects of pharmacology and dosing have been distilled into single-page protocols that I can teach any provider in 10 minutes or less. Finally, because we're not just acutely treating their withdrawal, but also starting them on their chronic treatment that they're going to be on for a long time, it's really important that these patients get referred into treatment and follow up as soon as possible. We're not just giving them a piece of paper and saying, call this number and try to get in. We're really strengthening that link between the emergency department and their outpatient follow-up treatment program. It's just like treating a diabetic patient with hyperglycemia in the emergency department. We try to treat the crisis by lowering their glucose and also make sure that they get into treatment so they don't just wind up back in the ED tomorrow. Like I mentioned earlier, there's really been an explosion of materials to guide clinicians and help simplify the process. Both ASAP and an organization called the California Bridge Program have published a variety of clinical tools for pretty much any situation a provider or a hospital might encounter. This includes a clinical dosing algorithm for providers to use in the emergency department, guidelines to manage acute pain for inpatients already on buprenorphine, separate guidelines for pregnant patients or perioperative patients for the anesthesiologist to use, and even P&T monographs and formulary requests for hospitals that might not already have buprenorphine on formulary. I know this sounds like a complex process change and perhaps something new for a lot of physicians, but it's actually really simple. At the end of the day, all we're doing is treating opioid withdrawal with the best medication that we have to treat withdrawal. Before we used buprenorphine, we really weren't doing a great job treating symptomatic withdrawal. And like Greg said, oftentimes we're admitting these patients who are in severe withdrawal or are having complications of withdrawal. Now when patients come in suffering from even extremely severe opioid withdrawal, we can get them to symptom-free within an hour or two and facilitate rapid outpatient follow-up. Here's the strongest data we have to support the use of MAT for opioid use disorder. This graph demonstrates the results of a meta-analysis in what's called a forest plot. Each row represents another randomized controlled trial of MAT. with all of the solid squares showing mortality rates among patients who are on MAT compared to patients who are not on MAT, which are shown by the white squares. You'll notice that most of the studies here were evaluating MAT with methadone, but that's because it's been around for decades. But even among the more recent randomized controlled trials of buprenorphine, the 3 studies at the bottom of the chart, the pooled mortality seen among patients on medications was dramatically lower. Now, what does this look like from the patient's perspective? Well, patients with opioid use disorder have traditionally bounced around between different healthcare settings and are often our system's most frequent flyers and highest utilizers, like Greg said. As an emergency physician, these are often the patients who I know by name, sometimes coming in for medical clearance for jail, sent on a 5150 for suicidal ideation, frequently hospitalized for bacteremia or other complications of use. But despite their high use, they often fail to make it into treatment and break this cycle of use. And I think that one significant reason for that is because all along we've been failing to offer them the treatment that they need when they're in our care. It turns out that offering patients treatment at their time of crisis is incredibly effective. Hospitals that are implementing MAT programs in their ED are finding that this is often when patients are most motivated to make a change in their behavior and change their use patterns. MAT brings a lot of value in that moment. Instead of offering merely words of encouragement, counseling, or referral, I'm actually able to give them something that will simultaneously eliminate withdrawal and cravings and connect them to a treatment program and support community and help them return to a healthy lifestyle. Here are the results of the other major landmark study that demonstrated efficacy and feasibility of this model. In 2015, researchers at Yale published the results of their study where they randomized emergency department patients presenting with acute opioid withdrawal to one of 3 arms. In the first arm, they were given a referral to a treatment program. In the second arm, they were given a brief counseling intervention followed by that same referral. And in the third arm, which is the red bars in these graphs, they were initiated on buprenorphine in the emergency department and then given the same counseling and referral. Not surprisingly, patients who were actually started on buprenorphine in the emergency department had a near doubling in their 30-day treatment retention and less than half the self-reported rate of opioid use after emergency department discharge. I wanted to briefly highlight some of the key steps to implementation that need to be addressed by the hospital to ensure a successful program. The first step is getting buprenorphine on formulary. This is becoming more common on hospital formularies as it's increasingly already being seen on patients' home medication lists, but if it's not on formulary, it's absolutely worth discussing this with your pharmacy. It's also very important to meet with your local outpatient treatment program to build a really solid handoff process to prioritize emergency department and hospital discharges for early follow-up. Sometimes that's a federally licensed opioid treatment program or possibly a federally qualified health center, though sometimes a certain geography might not have any provider available. In these cases, we often partner with telehealth organizations like Bright Heart Health that focus on treating patients with opioid and other substance use disorders. Once the medications are available and the follow-up plan is determined, the final step is clinician education, which involves educating both the physicians and also the nursing staff, case management, and pharmacy to make sure that everyone's on board with the new process. Over the last few years, a lot of educational materials as well as protocols have been developed to help streamline this process for implementation at hospitals looking to adopt MAT programs. One of the organizations leading the way is called the California Bridge Program. The California Bridge Program was launched by researchers and leaders in emergency and addiction medicine, including Andrew Herring at Highland Hospital. In 2019, they partnered with the California Healthcare Foundation, as well as the Department of Healthcare Services to provide grants to over 50 California hospitals looking to accelerate the adoption of ED-based MAT. And here's a map of where all these hospitals are. We're now over a year into the program and seeing many sites within and outside the official California Bridge Program implementing the protocols and launching bridge programs of their own. We're particularly excited to have so many Dignity hospitals and Vituity providers participating in the program. And as the data starts to roll in from the participating hospitals, we're seeing some really excellent and impressive results. The first program to launch was Highland Hospital in Oakland, and here's the data showing the number of patients treated per month, which just continues to rise as providers become familiar with the treatment protocols, and patients learn that they have a safe place to go to initiate treatment when they are in crisis. I think the data is really promising. I wanted to hand things over now to Candace Fong, System VP of Medication Safety at Common Spirit Health. She's been a partner of ours in these projects and has been really exciting to see the successes demonstrated throughout her hospital system.
Thanks, Dylan. As Dylan mentioned, that I am the System Vice President for Medication Safety at Common Spirit Health. Some may wonder, well, let's see, what's Common Spirit Health? Common Spirit Health actually is a merger between Dignity Health and Catholic Healthcare Initiatives, and that happened last year, about a year ago. But we will refer to our affiliate hospitals as Dignity Health because we began this journey early in 2019, and as both Greg and Dylan mentioned, it was a California Bridge program that was a grant program that was made available in 2019. And within Dignity Health, we have about 24 hospitals in California, so this became an opportunity for us to really make an impact with the opioid use disorder and the crisis that's happening, and have our hospitals be active participants in this. So as you can see, the red dot are the different MAP programs that are actually throughout our system in California and Nevada, but the star are the grant-funded hospitals. So those are the bridge programs hospitals, and we represent about 23% within the California Bridge program. So it's been a very active program for us to move forward. As you can see within this, we have our Dignity Health hospitals have about 1.8 million ED visits with about 697,700 opioid use overdose visits annually, and it amortizes out to about $4 million in the cost of the organization. So we knew that this was a situation and an opportunity for the organization, so we collaborated closely with Vituity. They represented presence in many of our emergency departments, so as you can see between Greg and Dylan, it was an excellent partnership for Dignity Health to embark upon. What I wanted to do is actually drill down a little bit further and within Sacramento County as I focus in on a specific facility to illustrate how the system had embarked upon this. The Sacramento County area, it was just a snapshot of one of the few areas that we wanted to zero in on, and this is about 6,000 individuals within the county that really have no access to treatment. So knowing that, you can see where Sacramento lies. It's about 1%, a little over 1%, where those individuals really can benefit for having a program within the county. So this is, again, one of our hospitals that will illustrate they had about 81,000 visits with about 48 opioid overdoses. So it really nets out to about $300,000 in cost for these opioid overdoses, albeit this only represents what was captured with the coding, as we're all very well aware that we're faced with challenges in retrieving data. So this was the best that we were able to kind of capture the costs associated, but we all are well aware of the opportunities with patients that are coming in overdoses. So what did we do with this? We knew that with the MAT program, there are the patient transitions and how do they get through the care. They show up in our emergency departments, and we want to adequately treat them and then be able to refer them out to the community clinic. With this program, it really is initiate therapy and refer. So we had to make sure that we had this continuity of care for the patients to ensure that they had success in their treatment. So driving the buy-in. Within the program, we had the opportunity to really change the culture and remove the stigma. We began the journey, and it was really new to our emergency departments. We really had to educate the nursing staff as well as the clinicians. We had champions in many of these sites, so that was a good, positive effort because they were the clinicians that were really driving the change. But We also recognized quickly that the nursing staff, because there were many more nurses than the physician champions, and they had a stigma. They had a stigma for these patients. So we really had to work hard on educating them that this was the right thing to do, and it really did improve care. And so we had to bring them along with the buy-in. We had to also bring the conversation to the facility leadership. The senior leadership at the C-suite level really had to understand what the benefit was to the organization, to the population in providing the immediate treatment and care. So it really was an overall educational piece of the buy-in for them philosophically to move this program through. So at a system level, because we had 24 hospitals in California with about 11 of them as part of this bridge program, we readily recognized that with 11 different hospitals, 11 different personalities and cultures, that we needed a standard approach. So we actually developed a toolkit for the implementation of this program because it was a grant-funded program. The grant had deliverables, and as an organization, a large organization in California, we also had to be mindful of many of the regulatory compliance aspects of moving a program of this nature across our organization. So we felt after many conversations, and these were several conversations that I had individually with different hospitals that reached out and said, well, how do I do this? How do I do that? I found that I was on the phone an awful lot, repeating myself. So I worked with a physician lead, and we worked closely with the California Bridge program in developing this toolkit. So the toolkit actually goes through many of the aspects of the grant requirements, but the toolkit will also provide a support for many of our non-grant hospitals wishing to implement a MAT program as well. So that was a great need and something that was very valuable to really standardize our approach within the system. So what does this look like from a system implementation process? Looking at and really taking in all of this information, because recognize it started in early 2019. The hospitals individually wanted to apply for the grants, and then we adopted a system approach to apply for the grants, and then we had questions as the grant money started coming in. So we really said, we really do need to address this system-wide. So we implemented a timeline with the deliverables, and we started with many conference calls, WebExes that brought these 11 facilities into the discussion and say, okay, what's your timeline? What are your deliverables? Making sure that we met those timely deliverables. We also looked at standard order sets. As Dylan mentioned, there are algorithms available, and the California Bridge program did establish that, but we have one EHR across our system. So it really made sense for us to establish one standard order set, as well as to develop a standard job description, because the grant also had a stipulation that a substance use navigator, or what we call a SUN, was the individual that would be the key liaison with the patient, and that would be standard amongst these grant hospitals. So again, standardizing that job description so the expectations are the same across all of the grant hospitals. We did have a discussion at our system. We had a system pharmacy and therapeutics committee, so we added this to the formulary at the system level with the request that all the facilities add this to their formulary as well. So we adopted that piece. We actually had the discussion, should it be buprenorphine or should it be Suboxone? We said this is initiate and refer, so buprenorphine is perfectly acceptable as a generic drug to be added to formulary. We also discussed the X waivers and really what is the process for getting the education out to the clinicians and obtaining those, and who needs to have the X waiver. Once we got into the facility level, we found that there was an awful lot of confusion. Everyone thought that they needed an X waiver even in order to even give one dose in the emergency department, and we quickly expelled that information and said, no, you don't have to have an X waiver to administer a dose. The X waiver is required if you're writing prescriptions for the patients. So again, education and clarification as we went through this process. And then creating provider and patient information and education. We actually had posters developed for our emergency departments so that we could have signage for the patients coming in that if you need assistance, we're here to help. We also created documents for clinicians and patients on additional information, which I'll go through. So this is what we've seen as the benefits. We talked about what we needed to do and what we're seeing as the benefits now. We did develop the system order set. We did develop the system job description, and we actually also developed a process to create a memorandum of understanding. It was part of, again, the grant requirements that a agreement be developed between the community-based clinic and your organization. So we standardized that and created a standard MOU process that the facilities executed when they were developing the relationships agreements with their community clinics. We also developed, as I mentioned, the signs and the handouts, and also education for providers, because the Privacy Part 2 is a requirement, and we wanted to ensure that compliance with the federal funding. So that was another big piece where we had to educate our substance use navigators to what the consent and the privacy requirements were to be compliant. So I just quickly wanted to show you the SUN, as I mentioned, Substance Use Navigator. We wanted to track their effectiveness. And so this is where they are able to interact with the patient and have a conversation and offer them the ability to initiate the buprenorphine treatment. So you can see, and this is just a snapshot, September we had about 33%, but as we went up into December, 44%. And so this was in our 11 grant hospitals, and just measuring what the effectiveness is of that navigator for patient acceptance. What I want to do now is just to really show you, this is all of our sites. Whether they had a grant or a different MAP program in place, we measured what our doses of buprenorphine were. That was an easy, quick measurement. As many of you that are doing metrics totally understand that getting data is oftentimes difficult. But since we had a single EHR throughout our system, it made it very much easier for us to really analyze. So you can see the gold bars are 2018 data on where our doses were of buprenorphine. Now recognize we were 38 hospitals in Dignity Health at that point when we did this measurement. And now you can see the orange in 2019 when we began the grant programs, and you can see the escalation in the doses of buprenorphine. So we're really quite pleased with that and the growth of it. So having a system approach with these MAP programs has been extremely beneficial, monitoring our metrics and the patient stories. The patient stories have been incredible. You have individuals that are very pleased with their progress. We had individuals tell us that, you know, they had opioid use disorder, they were able to complete their buprenorphine, and they were able to have a very normal life where they were actively employed and had a family, and it bode well for them. Secondarily, we also found just something else that was a sidebar identification, is that we find that many of the prescription plans may not have buprenorphine as a formulary drug or accepted drug for the outpatients, for those that are covered by insurance. So it was a learning for us as we started to work with some of these health plans, really to educate them. So I think the health plans are the next group to be educated to facilitate and address the patients, because that your patients with opioid use disorder are not just those that are uninsured. Many of them are very insured, and so we have to assist them in moving forward with this. So we have very positive thoughts with this, and the goal is to deploy additional MAP programs across Common Spirit Health because we are in 21 states. So we look forward to moving this program forward. Now I'd like to hand it off to Greg again.
Thanks, Candace. I mean, just tremendous hard work at Dignity or the Common Spirit. The emergency departments in the system are just doing amazing work, life-saving work for their patients. So to summarize, we've seen that MAT in the emergency department can be an efficient system that provides hope to both patients and to staff as well. ED-MAT improves the quality and access of care, quality of care and access for these patients, and it creates a more efficient and safe system for both our patients and our staff. Buprenorphine should be available in every emergency department in the United States, and referral systems need to be built to link patients from the emergency department to outpatient treatment centers. MAT is a life-saving and cost-effective treatment. We know it's part of the solution to the opioid crisis, and it's a way to address the billions of dollars in costs and the climbing rates of drug overdose deaths that we're currently experiencing in our country. Once implemented, ED-MAT is an easy process with just a simple referral to an outpatient treatment facility. It's incredibly easy as a practicing clinician. I can attest to that personally. The ED is a great doorway into this system, and we're really the only portal that's open 24 hours a day, 7 days a week, 365 days a year, when we're accessible in just about every single community. By delivering MAT in the emergency department, we're going to increase follow-up rates. We help patients manage their withdrawal and follow up with the community addiction treatment centers. We know this is a life-saving treatment. We've seen this in our own Vituity and Dignity emergency departments, in the messages that patients have sent our doctors and substance use navigators after we've started up our MAT programs. If you're ever interested in partnering with us to help build an ED-MAT program in your own emergency department, we'd certainly be happy to talk to you. You can send an email to solutions@vituity.com. So we really appreciate your attention, and we're now open for questions.
Perfect. Well, thank you, Dr. Miller, Dr. Carney, and Dr. Fong for such a great presentation. We'll now begin today's question and answer sessions. Please submit any questions you have by typing them into the Q&A box you see on your dashboard. We'll try to get through as many questions as we have time for. Looks like we already have a ton of great questions rolling in. The first is from an audience member who asks, how quickly upon admission to the ED are you providing induction to MAT? And maybe Dr. Carney, you can take that one.
Yeah, that's a great question. We are starting them on arrival. I mean, as soon as they get into a room. So in my emergency department and a lot of the sites that I work with, this is something that is done out of RME, or the Rapid Medical Evaluation Area, for patients who don't need IVs. Which is a real change, because in the past, if someone came in with severe withdrawal, vomiting a lot, dehydrated, sometimes we needed to put them in a room, get an IV, give them multiple rounds of IV medications, and they might be there for a long time. These patients are getting their first dose of buprenorphine. It's in our Pyxis in the emergency department, so they don't need to send anything up from pharmacy, and they're getting it right when they're getting to the room.
Perfect. Thank you for clarifying that timeline. Let me stick with you for the next question. Is a DEA-X waiver required for all providers on the team?
It is definitely not required. So as Candace alluded to, so the DEA-X waiver, for those who aren't familiar, it is a waiver to prescribe this medication specifically. So the DEA requires that anybody with a DEA license, any physician, if they want to prescribe buprenorphine, they need to get a waiver, which you can get after an 8-hour online course. The course is free, and it's done in person at many hospitals and throughout the country. But that's only required if you plan to write a prescription. When you're practicing within a hospital system, all of the providers who are administering buprenorphine are doing so under the hospital's waiver. So we actually don't need to prescribe them medications if they can get into follow-up in the next 1 to 3 days.
Perfect. Thank you again. This next question is about screening, and it's asking, What screening tool do you use to screen for OUD in patients entering the ED?
I'll take that one too. There are some systems that have built in formalized screening tools. There's one that I've seen frequently used called the Rapid Opioid Use Disorder Screening Tool, or the RODS, and that goes through some simple questions. And then there are other tools used to assess level of opioid withdrawal severity. And so the COWS is the one that's frequently used, the Clinical Opioid Withdrawal Scale. And the COWS function similar to the CWA score for alcohol withdrawal. And so some systems are formally implementing the COWS and putting in a floor of a score of 8 or higher in order to get buprenorphine. Although some systems are moving, and a lot of the leaders in this space are encouraging clinicians to start the medications if a patient has objective signs of withdrawal. So you can see that they're actually sweating or they're vomiting. And so implementing a formalized scoring tool that you need to change your EMR for is not something that every hospital needs to do, although some are opting in to do that.
Dylan, if I could chime in too on that, I totally agree with what you're saying. And I think what we've found just anecdotally is the best question is just to train the clinicians to ask, are you interested in a dose of buprenorphine right now? Most of these patients have had experience with it in the past and know if it's something that will help them in the acute setting right there in the room. Certainly screening tools can be helpful at times, but sometimes they can also get in the way of providing the care that's necessary. And the most important thing here is, regardless of what gets screened positive or negative, training your clinicians to ask patients, do you want a dose? Can we help you right here in the emergency department?
Great. Thank you both for weighing in on that one. This next question may be best for Dr. Carney to answer. The audience member is asking, is buprenorphine the only drug used in the MAT approach?
It is not. So there are 3 FDA-approved medications for MAT. There's buprenorphine, and I will say Suboxone is the same thing, and there are a couple other questions there, so I'll put a pin in this and come back to what separates the two. The second medication is methadone, and the third is naltrexone. Naltrexone you can think of as a long-acting injectable opioid antagonist or blocker. It's like a long-acting injectable Narcan. And in the addiction world, there are certain patients who might be better for one or another of these options. And so naltrexone is effective. They're all very effective. But out of the emergency department, buprenorphine is the most feasible. Some of these patients may end up switched to methadone if that ends up being a better fit for them in the long run. But we're finding more and more patients are appropriately staying on buprenorphine. The difference between buprenorphine and Suboxone is that Suboxone has Narcan in it. Both medications are sublingual. And we prescribe Suboxone when a patient is taking it outpatient. So they're going to the pharmacy and filling it and taking it home. And the Narcan that's in there is used as a deterrent to deter them from trying to liquefy it and inject it. And so if they were to inject it, the Narcan would be completely bioavailable and it would cause withdrawal. But when you take the Narcan sublingually, it's inert. It's not bioavailable at all. So a lot of hospitals are using buprenorphine in the hospital because it's generic and cheap and equally effective. And then when patients get their prescription from their provider, when they follow up, they're usually getting Suboxone.
Got it. I think that's helpful for our audience to know, so thank you. Dr. Fong, let me turn to you for this next question. This audience member is asking, how do you recommend identifying and developing relationships with community treatment partners?
That's a good question. And we have community health divisions within each of the hospitals, and they are an excellent resource to really work with that. We also know that the community clinics have also reached out to our hospitals because they're aware that the MAP programs are going in or that they have services to offer. Because I've had many community clinics come to me and say, well, we know that this hospital is close to us, but they don't have a MAP program yet. Can you help us develop a MAP program so we can have a referral base for the patients? So I think there are a lot of different methodologies and approaches, but I think community benefits can help with that, your community services, as well as the clinics coming to you.
Perfect. Thank you so much for touching on that, Dr. Fong. Dr. Miller, let's turn to you for this next question, which is, can telehealth services be incorporated, especially for hospitals in rural communities?
That is a great question. Yes, absolutely. I think telehealth has a lot of potential here, and there are companies out there that are providing services. Work It Health, Bright Heart Health are the names of a couple. I'm certain that there's others out there. In my own community, we see boots on the ground clinics, like brick and mortar clinics, that are augmenting their services with telehealth as well, so that they can expand the impact of an X-waiver provider. The majority, or at least a couple of years ago, there was a study that came out showing that the majority of counties in the United States don't have X-waiver providers that are available to prescribe buprenorphine. And so I think telehealth has a lot of potential, and there are certainly a lot of companies moving into this space.
Perfect. Thank you so much for touching on that. Dr. Carney, let me turn to you for this question. This audience member is asking, what prevents patients with using an ED as a pharmacy when given right away after triage?
That's a great question. I would say the biggest factor is that it's not very euphoric. It's not typically these patients' preferred opioid that they're using to get high. And so it kind of dovetails on another question I've seen pop up in the list a couple of times is this a medication that's diverted, and kind of what's the street value for it? There have actually been a bunch of studies of this, and it is a medication that's diverted, but when you ask the patients who have used it in a diverted setting, they've used it for its intended purpose. They've used it because they've been withdrawing and they've been trying to taper themselves off of their use, and they need something, and they know that buprenorphine is the treatment. So it's not really sold on the street for patients who are looking to get a high. People are lending it to their friends because they don't have access to someone who can prescribe buprenorphine, and they want to get off of use. So we've been doing this in my hospital for a number of years, and we're not seeing many frequent flyers come in for repeat doses. I saw one person come back in because she had been on the medication for a year. I saw her on year number 1, and she started it under my care. And then a year later, I think she was traveling and she relapsed, and she came back, and I think her provider had moved away and she wanted to start treatment again. So she came back in because she wanted to reinitiate treatment and figure out where to go. But it's not something that we're seeing people divert for kind of recreational use.
Perfect. Thank you again, Dr. Carney. Dr. Fong, let me ask you the next question. What other state-funded grant programs exist to help fund this program?
Very good question. I was recently back in Washington, D.C., helping to meet with the legislature and to really advocate for more funding for these opioid use disorder. There is a vast amount of funding coming out of SAMHSA, and for those of you that, whatever state, reach out to the state level because they are receiving this grant funding, and they have traditionally been able to communicate that out. But if you've not been on a listserv or any information, reach out to that level because there is a vast amount of money being allocated from Washington. So don't be shy and see what's available in your states.
Wonderful. Well, thank you so much, Dr. Fong. Looks like we have just a few more questions about the DEX waiver. Let me see. What are some specific training objectives for physicians and medical residents that medical education programs can integrate to improve physician readiness to deal with OUD?
I can take that one. So if you're coming from an academic residency program, I think it's certainly a great idea to get your residents X-waivered, which is an 8-hour course. It can be free, and some component, if not all of it, can be done online. If you are in a community hospital working with physicians who are already out in practice and are working full-time and have family obligations, other work obligations, it's going to be much more difficult to get those clinicians X-waivered, although certainly there's a lot of effort to do so, and there's grant funding out there that can help these clinicians get X-waivered. Again, it's an 8-hour course for physicians. For nurse practitioners and physician assistants, it's a 24-hour course. I think the key point is to realize that you can start up an MAT program without anybody being X-waivered. You might get some pushback from clinicians saying, well, we can't do this, nobody has an X-waiver. And the honest truth is, in my own emergency department, there's not a single emergency department physician or PA that has an X-waiver, and yet we have successfully induced more than 100 patients in the past year. This is not at all, I mean, it's certainly a nice to have, and if you have a team that's engaged and willing to do it, it adds to the scope that these individuals can write a prescription for 30 days and help bridge the patient into treatment. But if your clinicians don't have X-waivers, it's certainly no excuse to not start up a program.
Perfect. Thank you so much for outlining more about that waiver. I think it's helpful for the audience to hear. Dr. Fong, this next question is for you, and it is, how have you successfully encouraged participation of providers in primary care practices to be involved in continuing treatment?
That is a very good question. The initial focus was to establish the MAT programs in our emergency departments so that we could initiate treatment and refer them to a community-based clinic. Our next goal actually is to go to our ambulatory sites and with the primary care physicians and really to have that conversation. We have one site I will share quickly is that we do have a community-based clinic in Minnesota with one of our hospitals that had developed this, and they've been extremely successful in setting up this community-based clinic and monitoring the patients and really engaging the entire community so that they've actually been able to establish buprenorphine treatments within the jail system and been able to mitigate the individuals having to be put back into the jail because of issues with opioid use disorder. So they've been very successful in that. We're hoping to replicate that program, but again, it's a work in progress, and it really is, I believe, finding that champion, finding someone who's got the passion, and they will go a long way with assisting you in connecting that ambulatory piece.
Wonderful. Thank you for elaborating on that a little bit, Dr. Fong. I appreciate it. Dr. Carney, let me ask you this next question. How do you address pain exacerbations in a patient transitioning to buprenorphine?
That's a really great question and one that's relevant to kind of all of our providers, even at sites that don't have NAP programs, because patients are coming in with pain exacerbations already on this medication. And kind of similar to methadone and any other kind of opioid, when we're admitting someone, say they have broken their ankle and they're already on buprenorphine, the first thing we do is we continue their buprenorphine at their usual dose and consider that their baseline. And so we don't peel that off and try to replace it. We continue their buprenorphine, and then we just treat as we would on top of it. And we try to really focus on our alternatives to opioids because buprenorphine partially blocks the opioid receptor. So it's even more important to consider the Tylenol, ibuprofen, things like ketamine for pain, or regional anesthesia, and keeping in mind that we can and should still use our opioids, but they'll be slightly less effective, so you might need higher doses.
Perfect. Well, thank you again, Dr. Carney, for touching on that. Looks like we have another question here. This clinician is saying that I have my X-waiver and completed an executive fellowship at my local medical center, but the difficulty I have is not knowing how to set up an MAT clinic in the community.
I can talk a little bit about that.
Maybe how they might help. Perfect.
Yeah.
Thank you.
Yeah. Yeah, I mean, this is the biggest challenge for an emergency. I'm assuming the clinician here is an emergency physician or an emergency PA or nurse practitioner and is looking for an outpatient referral resource. This is probably the biggest barrier to setting up an ED MAT program is as much as we pass out buprenorphine in the emergency department and get patients started on it, we need to get these patients into follow-up within the next couple of days. There is a lot of grant money flooding the states right now, and there is maybe a lot more availability than you're aware of. If you looked a year ago, you know, maybe something has changed in the subsequent year. There's a lot more availability right now. A couple of things to consider would be to go to the SAMHSA website. They have a DEX locator function where you can type in your zip code or your location and find who are the other X-Waiver providers in your community are and see if you can connect with one of them. You can connect with your department, your state Department of Health, which might be trying to get some MAT programs funded and up and running in your local community. And then the last thing to consider would be if there's like an academic medical center or other large medical center, maybe they have some residency programs that have family practice residents or internal medicine residents who would be looking for some patients out of the emergency department. Again, and actually one more thing to consider would be telemedicine. Companies like Bright Heart Health might be able to establish some follow-up with your patients. Again, this is the biggest nut to crack is trying to get that outpatient community partner for an emergency department. So you got my sympathies. But once you get that partner, it makes a huge difference to get this program up and running.
Perfect. Well, it looks like we have time for one more question, which is, are you crossing these programs into the inpatient side of care at all?
I'm happy to answer that one. Oh. Candace, do you want to go for it? And then maybe...
Well,
yeah, I'll share my experience.
Okay, go ahead.
Well, we can talk to you. Yeah, yes, our goal is to educate everyone throughout the inpatient setting. But as soon after we launched our program in my emergency department, I had a patient who I had started, and then they developed some other problem while they're in the emergency department, and I had to admit them, and I just spoke with the hospitalist and kind of trained them on the spot. And over the last year, we have gone to every department meeting, from the hospitalist to the intensivist to the OBGYN department meeting, and kind of done mini trainings for all of them. And a lot of these providers have on their own gone out and taken the waiver training course online to get their DAX waiver. So now we have waiver providers in every department, and that has really built kind of a strong team of supporters to kind of help treat any patient regardless of where they may be in the hospital and who may be taking care of them. And so I think that's definitely the future of what we're trying to accomplish.
I agree. We actually extended it to several of the hospitals have extended treatment to the inpatients as well as the OB arena as well. So they do have specific algorithms for your pregnant moms, and so they are able to enlist that dosing regimen as well. So we have expanded, and many are doing the inpatient initiation.
Wonderful. Well, that is all the time that we have left for today. I want to thank Dr. Miller, Dr. Carney, Dr. Fong, and Vituity for their insightful presentation, and to our audience for participating. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.